Thank you very much. Assalamu alaikum. So we'll go fast just for the sake of time. So our patient is 81-year-old female with a past medical history of diabetes, hypertension, coronary artery disease, had BCI to RCA in 2020, and presents with the NIHA class 3 heart failure symptoms. The ECG showed just LVH, no ischemic changes, normal conduction, and the labs were also unremarkable with normal hemoglobin and normal creatinine. She had angiogram, which showed a patent stent in the RCA with mild ISR and no other obstructive lesions. Okay, I hope it's showing nicely there because it's like a little bit distorted here. So the LV function on echo is normal. And the aortic valve is severely stenotic. We see a mean gradient of 37. And of course, this patient also had a calcium score that was high, more than 2,000. This is the Brita VCTA, which showed an annular dimension average of 21.7 and no much calcium. The sinus is a little bit smaller size, but the most important issue here is we see the left main is 6.7 millimeter only, so low left main height with relatively small sinuses, with the left being 26.9 millimeter and the right is 23.5 millimeter. The axis seems to be okay, both sides. We didn't expect much issues here. So heart team discussion, we decided for transfemoral TAVR with the 23 millimeter Navitor and right femoral axis with ultrasound guidance and left main coronary protection in view of the low left main. So we decided to put a stent and be ready for a Chimney procedure. No predilatation. And of course, we had some issues starting with the axis. It was a little bit difficult to advance the sheath. Also, it didn't look that bad. So here the axis average dimension of about 5.7 millimeter. So it's above what we actually need, but it was a little bit difficult. Eventually, the sheath would pass. And we went ahead and deployed the valve. And again, we have been protecting the left main, and there was no issues. Eventually, this is the picture after we deployed the valve and removed the stent, not deployed, we removed the stent. So later on, patients went to CCU. Initially, she was stable, but suddenly she developed a sudden onset profound hypotension.
Can you stop here, Khalid? May I ask the panelist what could be the comes to your mind?
I mean, he could have had occluded coronary artery, mainly the left main. This would be one scenario. The other thing would be pericardial effusion. Also, can be a reason for that.
Okay.
Bleeding would be the third thing with the difficulties with the peripheral access, so I would keep that in mind as well.
Okay.
Yeah, I think important point you mentioned about, so risk of delayed coronary obstruction is still there. Actually, in the registry data, a lot of those patients who had delayed coronary obstruction, actually they had left main protection during the procedure, but it's removed. And once you remove the wire, and later on they can progress and they develop left main obstruction. So the patient was resuscitated with IV fluid, inotropes, and we did the usual survey, physical exam, and ABG, ECG, bedside echo. And based on all of this, the high suspicion was for retroperitoneal bleeding. So, and this is the approach, how to approach such patients. And of course, location does really matter a lot. If the patient is in CCU, hemodynamically unstable, then we should take the patient immediately to the cath lab. We shouldn't take this patient to CT room. That's where the patients die if they are hemodynamically unstable. So this patient actually was taken to the, immediately to the cath lab. And here we see the actual problem. So we see this free flow of blood from the distal right external iliac artery. This is the area we had trouble with advancing the sheath. Balloon tamponade, and with balloon tamponade, the most important is to check, make sure after you inflate the balloon is that there is no leak. Here you see, despite we are inflating at the site, it seems at the site, we are still having a leak. So we go a little bit more proximal, and now there is no leak. So we had this under control, and of course you wait for 15, 20 minutes, whatever, and then you repeat picture, and still the leak is still there. So it's not sealing, and we actually didn't expect it to seal because it seems to be a large defect. So eventually we had to put a covered stent, peripheral stent. So this is the stent, keeping it above the bifurcation. And this is the final result after the stent was implanted, confirming there is no leak. Also in the same session, we assessed the left main again, and it was okay, good flow, no issues there. Now the patient came back 3 weeks later with abdominal pain and palpable mass, something not very surprising. And this is the abdominal CT. You have huge hematoma, no active extravasation. And the question is what to do with this. Of course, no surgeon wants to take this patient, 80+ years old, for evacuation. So eventually we decided to treat this patient conservatively. Actually she is coming next week for a follow-up CT. So take-home message is retroperitoneal bleeding is a dreadful complication that should be anticipated, prevented, and promptly managed once recognized. Cath lab is the best place to manage unstable patients rather than sending them to a CT room. And basic peripheral intervention skills are essential for a successful TAVI program. Thank you very much.